Good morning. It's wonderful to be here in New York. When I left California on Thursday, it was 106 degrees. And so even though it's about 106% humidity by my standards here in New York, it's a much more pleasant temperature. And I'd really like to thank both Doctors Russell and O'Regan for inviting me. It's always a pleasure to speak at this conference, and particularly with this very distinguished faculty. And I'm most grateful that they even allowed me to come despite my genetic challenge, since I'm one of the 2 XY chromosomes that are now present on today's faculty. Some would argue that that's a good thing. Okay. Probably you. So I'm going to talk about the scintillating topic of neoadjuvant therapy. And we've had a love affair for many years with a neoadjuvant approach. And maybe that has something to do with this country, where we like it quicker, dirtier, faster, for the gal on the go who doesn't want to spend years waiting for information. But you'll probably detect by some of my comments today that that's perhaps not something that I'm entirely in favor of. But in any event, I'm going to review some of the recently presented data in neoadjuvant therapy, and then, of course, speculate on what this means for us. So 2011 was actually, I think, the better year for data in this subject area, since we had 5 trials that were presented both at San Antonio and at ASCO that really covered this topic. I spoke on this subject last year, so these are repeats of some of my slides from last year, and I'm not going to go over each and every data point for you in the interest of time, but really just a review of the topic, and this data has now been widely published and discussed in many settings. So the German group gave us Gepard-Quinto that looked at neoadjuvant therapy, utilizing epirubicin and cyclophosphamide along with docetaxel in a sequential fashion, and compared trastuzumab to lapatinib prior to surgery. I'm not going to show you the adverse events, etc., just the results. And what we can see is that there was a very nice pathologic complete response rate based on a central pathology review, with the trastuzumab arm having a rate of approximately 31%, and the lapatinib having a rate of approximately 21.7%. And if you compare this to other historical trials, principally done by the NSABP, this does compare favorably, and in fact is numerically somewhat higher than the average results we received in those studies. The second trial that was of importance in 2011 was the NeoSphere trial, which looked again at a neoadjuvant approach combining docetaxel with trastuzumab and pertuzumab. The novel combination of trastuzumab and pertuzumab alone without chemotherapy, and then docetaxel and pertuzumab in this 4-arm trial. It was a phase 2 study. Didn't involve a ton of patients, but it also was not terribly small either. You can see that the NeoSphere PCR rates here really were nice for the combination, and this was the first time that I thought that, in my mind, that we were beginning to see a glimmer that perhaps combination therapy may result in higher response rates. However, it's also important to note that the arm that did not contain chemotherapy, so trastuzumab and pertuzumab, also had an appreciable response rate, leading to speculation that perhaps there might be a subset of patients with HER2-positive disease that would not necessarily need to receive chemotherapy. What's also interesting is that NeoSphere was analyzed by hormone receptor status, and you can see clearly that individuals that had hormone receptor negative disease enjoyed higher response rates than those individuals that had hormone receptor positive disease, although it would be a mistake, I think, to conclude that you should not utilize this approach in hormone receptor positive disease, because you still have very nice PCR rates. Cher Lob, and again, animation, I'm just going to go through this very quickly, looked at paclitaxel with FEC done in a European fashion, combined with trastuzumab or lapatinib without either of these agents, with appropriate monitoring for toxicity, again in a neoadjuvant fashion. And I'm going to come back to the results in just a moment. And then Jenny Chang's group, the Translational Breast Cancer Research Consortium, also gave us this neoadjuvant study of lapatinib and trastuzumab in a neoadjuvant fashion without chemotherapy. Perhaps the most important study that was reported in 2011 was the NeoAlto study that looked at, again, the TKI versus trastuzumab in association with paclitaxel prior to surgery. These were in invasive patients. Inflammatory breast cancer was excluded, and there were 450 patients in total in this trial. Here are the efficacy results showing the PCR rates for lapatinib, trastuzumab, and the combination. There was no statistical difference between lapatinib and trastuzumab, but the combination, of course, as shown here, was better. If you looked at efficacy in terms of conservative surgery, there was a trend towards potentially being able to engage in conservative surgery, favoring the combination, but that was not statistically significant. This is a summary slide provided by Hal Burstein, looking at all of the trials that I've just mentioned to you, and the chemotherapy that was employed is listed in yellow at the bottom, and you can see the PCR rates with the various agents. And again, what's striking about this slide is that combination therapy appears to offer an advantage. Now, how that translates out over time is going to be interesting. But this is the data as was presented. And then, again, a summary slide looking at all of the trials that I've talked about vis-a-vis hormone receptor status, and the trend continues that ER-negative patients tend to enjoy higher response rates. Now, this was not necessarily groundbreaking information, since this differential response had been postulated before. But these are the first large data sets that we've seen that have really shown this in a prospective fashion. So let's move on now to 2012. 2012, we don't have a ton of data, and what we do have is primarily from the Germans. They were very, very busy, apparently. And the first study that I'd like to show you was presented at San Antonio 2011 by the German group, rather dourly, I must say, as I recall that presentation. And this is a comparison of survival according to pathologic complete response in HER2-positive breast cancer patients receiving neoadjuvant chemotherapy with or without trastuzumab compared to patients with HER2-negative tumors. It's a rather simple title, don't you think? So the objectives of this trial are listed here, and in reality what they were out for was to establish PCR as a surrogate marker. They compared distant disease-free survival and overall survival in the three subgroups listed, and also looked at the difference between hormone receptor positive and negative tumors. Again, in the interests of time, I'm not going to show you everything that was at that presentation, but it is available for you at the San Antonio website, and you can review it at your leisure. So these are the trials that the Germans have conducted that they included in this meta-analysis. What's interesting is that the Gepard-Quattro study does not yet have mature follow-up data, and so even though they listed it here in this list, they said we excluded it because we didn't have mature follow-up data. So it raised the question in my mind, well, why include it in your list then? But it's there nonetheless. So the methods were principally that HER2 status was known and was locally or centrally assessed. They provided their definition for hormone receptor positivity, and PCR was defined as no invasive or non-invasive residuals in the breast and lymph nodes. Here is the flow. There were 6,000 patients plus in this analysis. Those that were eligible were 4,300. And you can see that approximately two-thirds to three-quarters were HER2 negative, the remaining being HER2 positive. And then they subdivided it further into those patients that did receive trastuzumab versus those who didn't. And that was about 600 patients plus in each arm. Here are the patient characteristics. You can see that the median age is typical for this group. Grade 3 patients made up a substantial proportion of the patients, and approximately two-thirds were hormone receptor positive. Here are the results for distant disease-free survival and overall survival. In these graphs, Sort of the pinkish line, if you can see it, represents those patients who are HER2 positive who received trastuzumab. The blue line represents those who are HER2 negative, and the green line represents those who are HER2 positive and did not receive trastuzumab. And you can see, at least in terms of distant disease-free survival, the patients that were HER2 positive that did not receive trastuzumab don't do as well as the other groups in terms of distant disease-free survival. And again, this is not necessarily new information for us, but what is somewhat reassuring is this recapitulates prior data sets. Overall survival, you can see that there's not much difference between the HER2 positive with trastuzumab and, interestingly, the HER2 positive that did not receive trastuzumab, but that is explained a bit later. Here are the overall survival results analyzed by PCR. Again, the colors represent the same groups, and you can see that for those patients that did not receive a PCR, overall survival is pretty much the same. And again, remember the number of patients in the patient flow. So we have 3,000 patients that were HER2 negative and did not receive trastuzumab at all, because they shouldn't. If you look at, however, the overall survival results by PCR, you can see that those patients who received trastuzumab did very, very well. Again, those who were positive without trastuzumab did not do well, and those patients who were HER2 negative were in between. Their conclusion in this trial was that PCR can be considered, therefore, a surrogate marker for HER2 positive disease, at least in terms of response. And this raises the real issue that they're addressing obliquely is of HER2 resistance, and what does that mean? HER2 positive patients without a PCR are at a higher risk of relapse independent of trastuzumab treatment, and obviously that these patients need some new treatment options. Another study presented at San Antonio last year in December, was the Tryphaena study. This involved HER2-positive early breast cancer that was centrally confirmed. 225 patients randomized into 3 arms, principally utilizing FEC, one of the European standards, followed by docetaxel. And in this schema, pertuzumab and trastuzumab were given concomitantly with the anthracycline portion and docetaxel, sequentially with just the taxane, or in arm 3, vis-a-vis the BCRG study, the anthracycline was omitted and docetaxel and carboplatin as the chemotherapy backbone was employed. All 3 arms were considered experimental in this design. This was neoadjuvant, given neoadjuvantly, followed by surgery and trastuzumab to complete 1 year of adjuvant treatment. The primary endpoint in this study was, in fact, cardiac safety. They were interested in looking at the rates of symptomatic LVSD. The secondary endpoints were PCR, toxicity, etc. Eligibility criteria. All patients were centrally confirmed to be HER2 positive. The primary tumor was greater than or equal to 2 centimeters. They all had a normal preserved baseline LVEF. All had good performance status, and no previous anti-cancer therapy or radiotherapy was allowed. Here are the patient characteristics as shown here. Again, the vast majority of patients had an excellent performance status. You can see that operable disease was the majority. Despite the fact that there was central review, HER2 status was unknown in a relative minority of the patients, and that's interesting. Here are the cardiac events during neoadjuvant therapy. It should be also noted that this study was not powered to look at statistical comparisons between the arms, and so what you're getting is just numerical data. All right? And so that you can see that, interestingly, there were 2 patients in the arm that you might predict not to have any cardiac events, since the HER2 therapy was not given with anthracyclines. This is the arm that had 2 events. But again, in terms of percentages, for symptomatic LVSD, it was very low and not different from what we've seen in other trials. All grades of left ventricular systolic dysfunction is the middle box, and then decline greater than or equal to 10% and an LVEF below 50% is shown in the third box. And the numbers are similar. Other notable grade 3 or 4 events, there was higher rates of febrile neutropenia, at least numerically, in arms A and C. Diarrhea was also somewhat higher in the arm containing carboplatin. Here are the pathologic complete response rates. The first bar in each group of 3 looks at the PCR based on a definition of no invasive disease. The second bars represent the much stricter criteria of no invasive disease and no non-invasive disease. Again, depending, even with a correction for a stricter definition of PCR, we can still see appreciable pathologic complete response rates in this trial. How about breast-conserving surgery? The numbers are shown here. And a relative minority of patients were able to be converted from a planned mastectomy to breast-conserving surgery. The conclusions of the author included a low incidence of symptomatic or asymptomatic LVSD was seen across all arms, and they concluded that concurrent administration of combination anti-HER2 directed therapy did not result in any increase in cardiac toxicities compared to sequential administration or the anthracycline-free regimen. Neutropenia, febrile neutropenia, leukopenia, and diarrhea were the most common adverse events. There were high PCR rates, and that Tryphaena supported the ongoing affinity study looking at the combination therapy with chemotherapy in the adjuvant setting. It should be noted that the presenter was Dr. Schneeweiss, which translated means Snow White. At ASCO this year, we had some results from the NSABP's B41 trial, a HER2-positive trial, neoadjuvantly looking at anthracyclines, followed by weekly paclitaxel with trastuzumab, lapatinib, or the combination. The results, as announced at ASCO this year, looked at PCR rates in 519 out of 529 patients. 51% of these patients were node positive, 63% were hormone receptor positive, and the PCR rates are shown here, all in the 50 to 60% range. They noticed increased rates of diarrhea in the lapatinib treatment arms, which is not a surprise. There were higher PCR rates, again noted in the hormone receptor negative patients, which is a theme that has continued since last year. There were again similar rates of grade 3-4 LV systolic dysfunction, and the author's preliminary conclusions were that the substitution of lapatinib is effective and has acceptable toxicity, and that combined anti-HER2 blockade, while numerically greater, resulting in numerically greater PCR rates, was not statistically significant. And that may or may not have to do with the numbers involved in this trial. Avanther was also presented at ASCO this year. This is a neoadjuvant phase 2 study. It involved 44 patients, stage 2 or stage 3. They were HER2 positive, 58% were hormone receptor positive, and approximately 28% were hormone receptor negative. They were treated with weekly paclitaxel, weekly trastuzumab, and every 3-week bevacizumab for a total duration of 12 weeks neoadjuvantly. And as Dr. Cianfrocca, I think so aptly stated, bevacizumab is the drug that just won't go away. Regardless of how you feel about it, we're going to still see data sets with this drug. 36 patients had surgery at the time of this presentation and thus had results that PCR rates that were valuable, and a response rate of approximately 44% in terms of PCR was noted. Now, I'm going to do something that you shouldn't do, which is compare across trials because we do have different patient populations. But at first glance, without a p-value associated, it seems to me that the addition of bevacizumab hasn't done a heck of a lot, at least in this patient group. There were rare grade 3 adverse events. One patient was noted to have severe hypertension, and the authors concluded that the regimen was safe and effective, although I don't know if I entirely agree with those statements, at least in terms of what they were hoping for. So, ongoing trials in novel agents, CALGB 40601, looking at, again, trastuzumab, lapatinib, or the combination in association with weekly paclitaxel, has been accruing, and it may be near conclusion. I'm not quite sure if it's closed yet. And we'll get results from this approach, which is going to be a larger data set than what we've seen so far. I don't think anybody anticipates different results from the clues that we've had from smaller studies. Nonetheless, it will be there. And then this is a listing of novel agents that are in development. And I think what's important about the data that I've shown you in the neoadjuvant setting is it's really built a platform that has argued for combined therapy. And these are some of the agents that you'll need to keep your eye on in the future vis-a-vis that approach. Neratinib has already been discussed, and this is the drug also that apparently, according to Hal Burstein, has very acceptable toxicity. But maybe Hal is better at dealing with diarrhea than most patients are, I'm not sure. So we'll see. So also one other thing to keep your eye on, this was presented by the German group at ASCO, which is P95. If you can't read the slide, that's okay. That's not terribly important, but P95 is a monoclonal antibody that recognizes the C-terminal fragment of the HER2 receptor, and patients that have high levels of this tend to respond well to anti-HER2 directed therapy, and patients that don't have this don't respond as well. And so this approach or others like it may, in the future, although it's not ready for prime time, may in fact help us to decide which of those patients are going to do well with anti-HER2 directed therapy versus those who do not. So in conclusion, impact on clinical care. We've had some encouraging results from newly reported trials. They continue to establish a role for the neoadjuvant therapy of HER2-positive breast cancer. I'm going to go out on a limb a bit and say that combination anti-HER2 directed treatment is emerging as a potential standard of care, although it's not a great big small limb. I think that everybody's thought of that approach already. The question, though, in my mind still involves the relevance of PCR as an endpoint in differing breast cancer subsets. I remind you that PCR was established during the era of cytotoxic chemotherapy. And do the rules that we've traditionally associated with cytotoxics apply to targeted therapies or biologics? And I'll leave that question in your mind. So therefore, beware of phase 2 trials and the use of PCR as a surrogate for disease-free and overall survival. And just as a reminder, in neoadjuvant and adjuvant settings, trastuzumab remains a standard of therapy. Thank you very much.